Let's transition to triple negative breast cancer and the interesting diagnostic now around PD L1 too, and the new approval of atezolizumab in the metastatic setting and the locally advanced unresectable setting too, which is quite intriguing. You know, so very interesting development just yesterday. So, Hope, tell us about the Impassion 130, if you would.
Yeah, I mean, it's really exciting, I think, that we now have the first approval of a checkpoint inhibitor to treat metastatic triple-negative breast cancer. Impassion 130 randomized patients who had chemotherapy-naive metastatic triple-negative breast cancer at least 12 months from adjuvant or neoadjuvant taxane to receive nab-paclitaxel with either placebo or atezolizumab. And the endpoints included progression-free survival in the intent-to-treat population and also in the PD-L1 positive population, and overall survival in both populations as well. And the endpoints were tied to each other in kind of a funny statistical design way, but because the differences were so big, we sort of overlooked those statistical design areas, but which I think is clinically relevant. I mean, in defense of that, because we don't see, changes in such a big difference. And so the patients who went on, about 60% of them had their PD-L1 testing done in the on archival tumor samples versus metastatic tumor samples. And the PD-L1 was a specific test that I'll let Beth talk about a little bit more in a moment. And the results are actually, you get on a call when you're on the steering committee for these studies, right? And you look for those results. You're just waiting for that PFS. And the PFS slide was like, in intent to treat, it was a little under 2 months, and it was still, significant. But we thought, that's really a shame. And then we saw in the PD-L1 positive population, it was 2.5 months. Oh, that's a little better. But still, it's kind of small, right? That's a lot of money, and the risk of immune-related AEs, is it really worth it? And then we saw the overall survival data, albeit still very much interim, and we're looking for the final data with more events later this year. But in the overall population, a p-value 0.08, but in the PD-L1 positive population, a really impressive and never before seen overall survival difference of 9.5 months. Really very, I think, clinically relevant, even though there was this idea that you should see significance in intent to treat. Things change. So I think that difference is really remarkable, and it looks so similar to Cleopatra. It's so interesting to me that antibodies seem to change something about the tumor microenvironment, regardless of what they're targeting, because in Cleopatra, it was like about a 6-month difference in PFS, but almost a 16-month difference in overall survival when you added pertuzumab to trastuzumab. So it's really fascinating, and I think, it really sets a new standard of care. Now we have to check PD-L1 in all of our patients with metastatic triple-negative disease who aren't refractory to taxanes, and we'll hopefully hear later this year about alternative chemotherapy partners. Really well tolerated also. Yeah. And what about the diagnostics? How do we get the PD-L1 done here, Beth?
Yeah, so as Hope alluded to, the differences in the trial were most pronounced, of course, in the PD-L1 positive population, and about 41% of patients in the study were PD-L1 positive. And so the approval that came out yesterday is for PD-L1 positive patients, and this is where I think there's some important details that we need to be aware of. So what is PD-L1 positive? So the Genentech strategy for using PD-L1 as a biomarker has not been to look at PD-L1 expression on the tumor. Rather, they're looking at PD-L1 expression on the immune cells. So this is very different than some of the other already approved in other histology agents. In addition, it's a very specific antibody that they've used, so SP142 in the Ventana system. And so one presumes that, in fact, that was also approved as a companion diagnostic. Therefore, we should be using the SP142 to look for PD-L1 expression on the immune cells. So I think this is going to be very interesting for groups when they, go back to clinic next, because I don't know that many institutions have kind of, quote unquote, set themselves up to be testing this way, and I think it's going to be critically important for the breast cancer clinicians to work with their pathologists to recognize that this is a different PD-L1 test than what they might be using for their lung cancer patients. And I think it's, I've heard a few people say, well, our group is going to use EL22, some other antibody that they use already for, again, different histologies, and I think that it's an important study was done, not in breast cancer, but in lung cancer, called the Blueprint Project, and I think we were chatting about this before. So what the Blueprint Project did was to look in lung tumors using the 5 different antibodies that are available. And so those antibodies correspond with each different pharma and the drug that they've been developing. And just cutting to the chase, what they found was that the antibodies are all pretty interchangeable if you're looking for PD-L1 expression on the tumor, which remember is not what we looked at in the IMpassion130. Interestingly, even though they're all fairly comparable, it's the SP142 that's a little less sensitive for PD-L1 expression on the tumor. But if they looked for PD-L1 expression on the immune cells, which is the biomarker from the IMpassion130, there was a lot of discordance with the different antibodies. So I point all this out because I think we as a breast cancer community are going to have to address this, and we're going to have to address it first with respect to what we're going to do with initial testing, but I also think there's an opportunity to explore some of these other antibodies and see, I just gave you the blueprint data, but that was in lung tumors. Is it different in breast? Mm-hmm. Might be worth looking at.
And you have a project to do that.
Yes, we do have a project to do that. Yeah. So Hope and I are involved with an effort that is going to be trying to get biospecimens from patients who will now be treated with these agents as their standard treatment in order to ask and answer some of these important questions that the clinical trial perhaps didn't let us answer, but real-world experience will.
Mm. Does it make any difference to whether it's primary or metastatic disease? Should we try for one or the other to try to find that PD-L1? Or?
Well, I think that's what Hope alluded to, that 60% of the tumors are archival. Now, I don't know if that's, I presume that's from the primary tumor.
From the primary tumor,
so,
as far as we can tell.
Right, and so, I just went through this whole diatribe about doing the PD-L1 testing, but then the immunologist in me questions whether it is even that important. And the reason I say that is because PD-L1 is such a dynamic marker. So there's so much going on in the microenvironment that influences PD-L1 expression. For example, if you do have an immune response, what do CD8 T cells do? Well, when they recognize something as foreign, they secrete interferon. And what does interferon do? It upregulates PD-L1. So my contention would be that the metastatic microenvironment for the patients who are on this trial, and the patients we'll see in clinic, may be very different than in their archival specimen. So I think that we're going to learn more about this, and I suspect it'll be this year, because the Keynote trial that's looking at pembrolizumab in a very similar patient population, metastatic triple-negative breast cancer, had a little bit more rigorous requirement with respect to the timing of the biopsy relative to initiation of treatment. So we'll get a little bit more information. But this whole, we've, as a breast cancer community, been watching our colleagues in other histologies wrestle a bit with biomarkers. It's now our challenge.
I think actually this is a really important point, and the other trials that we're going to see is your own neoadjuvant trial and the pembrolizumab neoadjuvant to adjuvant trial, all of which will likely report in the next less than a year, we think.
Yeah, they're mostly fully accrued, I believe.
They're all accrued, and maybe by the end of the year. And those trials looked at PD-L1 but didn't require PD-L1 expression and used different antibodies between the two studies. It's going to be fascinating to see what we learn, and that may change everything.
Mm-hmm. Yeah, and as you're referring to the neoadjuvant trials, we may learn that the PD-L1 expression patterns could be quite different in that early stage disease from what we see in metastatic disease. So again, this is going to be, and then I suspect we all believe too that PD-L1 is probably not a single biomarker. I would anticipate, and based on data that's coming out from other histologies, that we'll probably have multiple markers that are pulled together to have a composite biomarker effectively.